Yeah. Is the voice audible now? Can you please punch? Yeah. Is the voice audible now? Can you please punch? Okay. Yeah, I think it is audible. Uh,
Yes.
okay. Hopefully, the voice is loud and clear for all of you, Doctor. Audio. Yes. That's good. Okay. So let's move forward. Now, what are the most common cataracts? Senile nuclear sclerosis, when we become old. Whenever the nuclear part of the lens happen to become sclerosed, that will alter the refractive index of the lens. And suddenly, the eye, earlier whatever the myopia is there, that is no more a problem the moment the nuclear sclerosis develop. So that is the reason it is called the second sight, which is the early vision change that happens. Earlier जो दूर की चीजें देखने के लिए चश्मा लगना पड़ रहा है, अभी नहीं जरूरत. Now most common congenital cataract is lamellar cataract. Galactosemia is oil drop. Diabetes is snowflake, not cornflake. Down syndrome is cerulean cataract. Hypoparathyroidism is a anterior subcapsular. Capsule together? Anterior subcapsular is hypoparathyroidism. Then Wilson's disease is sunflower. You can remember Wilson is copper, copper is yellow, yellow is sunflower. Right? How will you remember galactosemia? Tosemia, oil drop.
Oil drop.
Galactosemia is oil drop. Then diabetes is
Diabetes is snowflake.
snowflake.
White.
Then Down syndrome is cerulean. Then most common drug-induced cataract is steroids, and it lead to posterior subcapsular cataract. Right? So anterior subcapsular cataract is hypoparathyroidism. Posterior subcapsular is drug-induced. Now, what is the earliest visual change that occurs when there is a posterior subcapsular cataract? Typically, those who are taking steroids, glare and poor near vision.
With nuclear, second sight, but with
Senile nuclear cataract is second sight.
And here, posterior subcapsular is glare and
poor near vision. Indication for surgery. So, whenever the visual needs, there is a visual classification of the WHO of the blindness. So, based on that, we decide. So, what is the gold standard surgery? We do the phacoemulsification. We will melt down the lens with a. After that, we'll suck it out and put intraocular lens implantation. Shah Rukh Khan formula it is called SRK. SRK formula. If you want to know what should be the power of the intraocular lens, you need to calculate SRK formula. Power is inversely proportional to radius of curvature. Power is diopters, that is inversely proportional to radius of curvature. Then what is the best IOL position? There is a capsule, no?
Yes.
From that you did phacoemulsification. Inside that you will put the IOL. Now what is the posterior capsule rupture? What will happen? Lens ke piche kaun hai? Vitreous humor. So that lead to development of the seeping out of that jelly-like vitreous, and that lead to vitreous loss. The most common post-operative complication is typically you are doing emulsification, removing the lens inside the capsule,
Yeah.
and you are keeping the posterior capsule intact,
Yeah.
and that can undergo opacification, and once more vision problem will come. Posterior capsular opacification after a few months is the most common post-op complication. So whenever you have that kind of an after cataract, because of the capsular opacification, you do ND-YAG laser, that capsulotomy is what needed. Now, in rubella, what is the cataract? Central nuclear cataract. Then what is meant by brunescent cataract?
Brown.
It is a brown hard nucleus, and doing phacoemulsification is very difficult. Whenever electrical shock is there, you get anter-subcapsular, just like steroid intake. Sorry, steroid intake is
Steroid with posterior.
posterior,
Anterior
subcapsular,
is
anterior is
hypoparathyroidism.
hypoparathyroidism, even electric shock. Then most అది అయిపోయింది. ఇందులో నుంచి వస్తే మీకు ఎక్కడిపో. The most common uveitis is anterior. What is anterior uveitis? Iris, ciliary body, choroid. Choroid involvement is called posterior uveitis. Iris involvement is called,
Anterior.
and ciliary body involvement is called intermediate uveitis or pars planitis, is what we need to remember. Granulomatous uveitis may mutton fat keratic precipitates. So both the TB and sarcoidosis are granulomatous, but TB is non-caseous caseous granulomatous, whereas sarcoidosis is non-caseous granuloma, is what you need to remember.
Also in BKH.
Huh?
Walk Koyana
Walk the Koyanagi Harada syndrome.
mutton.
It is also granulomatous.
Yes, that is also mutton fat autoimmune.
And what is the non-granulomatous uveitis? Fine keratic precipitates. So most common cause of anterior uveitis ఏంటండి? HLA. What is paid? P ante psoriasis, A ante ankylosing spondylitis, I is inflammatory bowel disease, and R is reactive arthritis. These four are called HLA B27 associated seronegative spondyloarthropathies. Why called seronegative? Because rheumatoid factor and ANA, even serological markers are negative. In spite of that, they have got arthritis. And because pair and seronegative spondyloarthritis. Typically, they lead to enthesitis. Enthesitis means where the ligaments are joining the bone. At the point of the bony attachment, there is an inflammation. And because of that, what do you get? You get typically the axial skeleton involvement, with the sacroiliac joint involvement is more in the seronegative spondyloarthropathy, like psoriasis, ankylosing spondylitis, inflammatory bowel disease, and reactive arthritis is what you need to remember. Okay? అందులో you get anterior uveitis. Posterior uveitis involving choroiditis, you get in toxoplasma. So whenever iridocyclitis is there, what do you see?
Flares.
Typically, that lead to the
Flares.
aqueous humor get infiltrated with the
Inflammatory
cells that lead to aqueous flare is classical feature. Chronic uveitis lo emaitadi, there is a band shaped kerato ante enti cornea. Band shaped keratopathy is a complication of chronic uveitis. Then what are posterior synechiae? So typically the munde untadi iris ki mundu you have cornea.
Okay. Okay.
When the iris become adherent to the cornea before it, that is called anterior synechiae.
Okay.
Iris के पीछे क्या है?
Which
Lens.
lens?
The suspensory ligament of
Yes,
lens.
below that lens.
And they getting attached is called
Posterior.
posterior synechiae. So adhesion of the iris to the capsule of the lens is posterior synechiae. And when they found 360 degrees around the, that's a diaphragm shutter of your camera. ఉందనుకోండి 360 posture సినికే ఫామ్ అయితే యువర్ ప్యూపిల్ బికమ్ ఫిక్స్డ్, అది ఫ్రీగా ఎక్స్పాండ్ కంట్రాక్ట్ కాలేదు. సో దాంతో అప్పుడు దాన్ని ఏమంటారండి, సెక్లూషియో ప్యూపిలే, రైట్. దెన్ సన్సెట్ గ్లో టైప్ ఆఫ్ ఎ ఫండస్, రెటినా ఫండస్ సన్సెట్ అవుతున్నప్పుడు ఉంటుంది కదా గ్లో, అట్లుంటుంది. వాక్డ్ కొయనాగి హరాడా సిండ్రోమ్. సిమిలర్లీ candle wax drippings, because in sarcoidosis there is a retinal vasculitis. Around the retinal vessels there is just like candle wax drip అయ్యేటప్పుడు ఉంటుంది కదా, అట్లుంటుంది. గుర్తుపెట్టుకోండి, అని క్లాసికల్. Snow banking is a feature that is seen in intermediate uveitis. That means which is involving ciliary body. Then heterochromic iridocyclitis. That means iris, instead of having one color, it has got multiple colors. And such an iris undergoes inflammation. Heterochromic iridocyclitis is a feature of the Fuchs heterochromic uveitis. Then if you look at the HLA-B27 uveitis, it is unilateral, it is recurrent, is what we need to remember. Now, the most common cause of the infective uveitis is toxoplasmosis. Typically, it leads to posterior uveitis involving choroiditis. Put it together.
Yes.
Then, typically, uveitis and the inflammation of the uveal tract. So, any inflammation, RMPC, PMP, Raju, what will they give? Steroid. So, steroid manchide. Kaakunte, steroid will cause the raised ivopia and glaucoma can occur secondarily. Even though uveitis responds to steroid can lead to glaucoma. So what are the three classical features of uveitis? Uveitis lead to pain, photophobia, red eye. So painful red eye is the classical feature of uveitis. So how do you treat? Topical steroid only. And why do you give cycloplegics? Cycloplegic content is me accommodation కావాలంటే ఏం కావాలి, మీ suspensory ligaments are there, no?
Yes.
Suspensory ligaments which are holding your lens, they will cause relaxation. So typically whenever uveitis is there, the suspensory ligament will go into spasm. Ciliary muscle is the one which will lead to accommodation. Ciliary muscle contraction in turn will cause the effect of suspensory ligament that will decide the diameter and that will decide the focus. So andukosame the moment you develop hyper presbyopia means it is inability to read the nearby things, that is hypermetropia, that comes with older age. Because when you are young preparing for NEET PG, that time you are able to read the small font because your ciliary body will adjust, ciliary muscle. But when you become older, right, your refractive index become weaker, and that's the reason you need to overuse the ciliary muscles that lead to the eye strain unless you put the goggles, specs, right? గోవా అంటే ఇప్పుడే గాగుల్స్ మూడు స్టార్ట్ అయింది. సో అందుకోసమే uveitis ఉంటే ciliary muscle will go into spasm, and that is the one responsible for the pain. To reduce that, what you do, you give cycloplegic agent along with topical steroids. Finish. Now, conjunctivitis. Most common is bacterial, and most common organism among bacteria is Staph aureus. And purulent pus, hyperacute is Neisseria gonorrhea.
Most common.
Copious purulent discharge along with chemosis. Chemosis and edema of the cornea is what you typically come across. Right? Good to see 4 online classmates. Is it clear? Is the voice loud and clear, doctor? Very good. Good. Nice. Now, Gonococcus can lead to ophthalmia neonatal. And among the viruses, adenovirus is the most common viral conjunctivitis. Type 3 and 7 are called pharyngoconjunctival fever virus. Type 8 and 19 is called epidemic keratoconjunctivitis. Corynebacterium lead to membranous conjunctivitis. Chlamydia, generally any viral conjunctivitis will lead to formation of the follicles, follicular conjunctivitis. Now coming to trachoma, it is the Herbert-Spitz, which is the hallmark of trachoma. And Chlamydia trachomatis is the one responsible for trachoma.
Yes.
So it is the D strain, K strain, D to K strain, due to inclusion conjunctivitis. Atlane thyroid disease lo superior limbic keratoconjunctivitis. Similarly, spring cataract ante వాళ్ళకి allergic conjunctivitis ఉంటుంది. That's called vernal keratoconjunctivitis.
Young boys.
Yes.
అందులో ఏంటి papillae,
Yes, sir. Cobblestone.
follicular, papillary, రెండు hypertrophies ఉంటాయి. So viral infections of follicular, దీంట్లో papillary that lead to cobblestone appearance, which typically involves the upper tarsal conjunctiva. Similarly, there is an ulcer which will form in the cornea, which is of the shield shaped. Shield ulcer is characteristic. Right? Now, how do you know whether it is pseudomembrane and true membrane?
Pseudomembrane peel చేయొచ్చు.
True membrane on peeling will lead to bleeding. It is not.
Yeah.
Where is pseudo?
Easily.
The most common cause of neonatal chlamydia, because maternal vaginal tract itself is the source for chlamydia. So subconjunctival hemorrhage, if it is there, a lot of people will have, elderly people, subconjunctival hemorrhage untadi, painless untadi, and generally it will resolve spontaneously. That's all the story, doctor. Pack the ground. Now,
Safe strategy. Chlamydia.
Yeah.
ఒక క్వశ్చన్ విజువల్ ఫీల్డ్ డిఫెక్ట్ రాకుంటే మురళీ భరద్వాజ్ నే like optic neuritis, macular disease, they all central scotoma, right? And centrocecal scotoma is tobacco alcohol associated amblyopia. Then arcuate scotoma
Glaucoma.
is typically seen in glaucoma, and that is also the expansion of the germ scotoma lead to arcuate. Earliest in POG is
Paracentral.
paracentral. But pathognomonic of glaucoma enti?
Nasal step.
Adi Roini's nasal step, not earliest. Then altitudinal field cut eppudu vastadi? Typically whenever there is any anterior ischemic optic neuropathy. So ఇప్పుడు basic optic nerve is being supplied by central retinal artery. Central retinal artery is basically comes from the carotid circulation.
Yes.
So any disturbance in carotid circulation can lead to decreased blood flow through the central retinal artery, can lead to anterior ischemic optic neuropathy. Then one entire altitude పైననో కిందనో ఎగిరిపోతుంది.
ఒక field complete.
So junctional scotoma. So typically the central scotoma plus, typically it is seen in optic chiasmal lesions.
Yeah.
Then post chiasma aithe homonymous hemianopia.
Yes.
And it side temporal, it side nasal, outside nasal, it side temporal, like that. Then incongruous hemianopia. And the same fields undai. It side nasal botha atu temporal. Typically occur in optic tract lesion. Rendu sides temporal egiripotha adi congruous hemianopia, occipital lobe lesion. Occipital lobe, macular sparing will be there. Typically macular sparing lesion will occur in PCS stroke. Why macula will be spared? Because it has a dual circulation of both MCA and vessels of the middle cerebral artery and also the posterior cerebral artery. Then quadrant, superior, inferior quadrant. Superior ఎక్కడ ఉంటుంది? టెంపరల్ లోబ్ల, మేయర్స్ లూప్ అంటారు. ఇన్ఫీరియర్ ఏమో పెరైటల్ లోబ్ల. దీనిది దానిది పెట్టద్దు, ఎట్లా అట్లా గుర్తుపెట్టుకోండి. తర్వాత ఓకే. దెన్ టన్నల్ విజన్ దేంట్లో ఉంటుంది? ఇంతకుముందు అడిగినా రెటినైటిస్ పిగ్మెంటోసా. Similarly, advanced glaucoma unte
Yeah, glaucoma.
field become constricted. Occipital lobe లో పోల్ ఏరియాలో గనక ఉందనుకోండి, రైట్, అక్కడ కూడా స్పేరింగ్ ఉంటుంది. కానీ ఎక్కడ టెంపరల్ ఏరియాలో ఒక క్రిసెంటిక్ స్పేరింగ్ ఉంటుంది, అది కొంచెం బియాండ్. మాక్యులర్ స్పేరింగ్ ఈజ్ ఆసిపిటల్ లోబ్ అని అంటే మస్తు అమ్మో పురా. టుడే వన్ ఆఫ్ మై డిఎంబోస్, హీఈస్ FMG guy, 190 marks he got.
Oh, he's taking FMG.
FMG lane మొన్న జనవరి సెషన్ మే
January. Okay.
he got 190 correct.
Oh,
150 is pass mark, no?
Yeah, so it won't.
So in his batch it looks like there are 270 students in Ukraine. అందులో నుంచి 4 students got 150. 150.
Remaining all didn't get.
Huh?
The tough one.
Generally June session is considered to be tough. Be prepared.
Okay.
Compared to Jan. మొన్న Jan వాడు మొత్తం బోల్తా కొట్టించిండు.
Okay.
Only 23% passed. 76% sitting in home. See, simple thing appa. చదివితే automatically there is no, see, some people require 5 times reading, some people require 1 time, 2 times reading. But what you read should be like you're betting on the stocks in market, because time is the most permissive thing. More than memory, time is the most permissive thing.
Yeah.
So andukosam చెప్పి what I tell is to anybody is you play with any material throughout the year, but last 30 days ante there should be a standard thing, not more than 10 points or 20 points on a topic, and not more than 1000 topics compared to when we take all 19 subjects together.
Yeah.
When you have that precision dynamics, no one will stop you. Anyway, we did the best because we had been longing and combing.
Yeah.
In last 10 days we have made the best.
Yeah.
Especially you helped him in ENT, SPM.
Yeah.
Koncham ophthalmology also looks to be blossomed in his mind.
Yeah. Almost
Almost.
80 marks.
Akane మీరు extra 80 coverage with the entry of Mithuna.
Yeah.
ఏమంటావు మిత్ర? History will remember that.
Yeah, if he passes, nothing like it.
సో అట్లా అన్నట్టు. సో ఇక మనం ఎట్లాగో వి స్టడీడ్ మైక్రోబయాలజీ, ఫార్మకాలజీ అన్నీ ఒకప్పుడు చదివినాం కదా. అట్లా ఎప్పుడైనా ఫిజిల్ అవుట్ కాకూడదు. వి షుడ్ నెవర్ ఫీల్ దట్ వీ హ్యావ్ నాట్ డన్ ద బెస్ట్. ఆల్వేస్ వీ షుడ్ ఫీల్ వీ హ్యావ్ డన్ ద బెస్ట్ విత్ ఇన్ ద టైమ్. లెట్ us give the best attempt. Then what happens if you don't worry, your memory will be good.
Yeah.
Ultimately, when you write exam, no doctor,
Yeah.
nobody will be perfect in 19 subjects. They'll be decently perfect enough to rule out. Complete no-show undaddu.
Yeah.
Christmas tree pattern anangane, if you don't have not heard it one time also, you can't. Atla. So most common cause of blindness is diabetic retinopathy. Earliest finding microaneurysm. Pathognomonic feature into dot blot hemorrhages in case of non-proliferative.
Yes.
And which layer of the nerve fiber layer you have this hard exudates formed? Outer plexiform layer.
Retina.
And what are cotton wool spots? They are the infarcts in the nerve fiber layer. Then what is IRMA? Whenever there is a non-proliferative diabetic retinopathy, proliferative ante neovascularization అయిపోతుంది. When there is non-proliferative, then intraretinal microvascular abnormalities will be found. Microvascular. Right? So what is the hallmark? It is the macular edema. Macula is the central part of the vision.
Yeah.
Right? And color vision is perceived only at macula. It is dense in
Cones are
the
dense.
cones. So, clinically significant macular edema. It involves a fovea centralis. It is also called threatening, vision threatening macular edema. So, what is a severe and non-proliferative diabetic retinopathy feature? 4-2-1 rule అంటారు. అదేంటి జర మీరు చూడాలి తర్వాత. Whereas proliferative అంటే neovascularization. Then
Neovascular disc.
typically those vessels will rupture and bleed into unda 4-1 అంటే. Today at a drop of a line అసలు టైపింగ్ కూడా చేయక్కర్లే, మీరు దానిపైన ఇది ఇఫ్ యూ గోయింగ్ టు దట్ అండ్ క్లిక్ అండ్ ఆస్క్ ఇట్, ఇట్ ఈస్ గివింగ్. కాకుంటే ఇక్కడ కొట్టాలి, ఇక్కడ కొట్టి మీరు మాట్లాడండి.
అది మైక్ ఉంది కదా. Any one of the following.
4 quadrants more than 20 intraretinal hemorrhages.
4 quadrants more than 20 intraretinal hemorrhages
or microaneurysms in all 4 quadrants.
In all 4 quadrants.
Or in 2 quadrants venous bleeding.
In 2 quadrants venous bleeding.
Or in 1 quadrant intraretinal microvascular abnormality.
And IRMA in 1 quadrant. That is a rule of 4:2:1.
Any one of those 3, then
that's called severe NPDR. Now, typically, when there is a neovascularization, it undergoes the bleeding into the vitreous. Over a period of time, the vitreous will develop fibrosis. And vitreous के पीछे कौन है? रेटिना. और वो रेटिना को पकड़ के खींचेगा. इसको बोलते हैं ट्रैक्शनल रेटिनल डिटैचमेंट is typically seen in PDR. Yeah, audible.
Now it's finished.
Okay. Share screen. ఇలా ఎక్కడ షేర్
Ah, part.
Yeah.
No, that's a good way of
అంటే ఫ్రమ్ వాట్ మీరు చాలా సార్లు అన్నారు సార్, ఇది రాకుంటే నా పేరు ఇది కాదు అని, అది నోట్ డౌన్ చేసుకొని అట్లా లైక్ ఇంపార్టెంట్. అండ్ మాక్ టెస్ట్ లో అవి కూడా అట్లా ఆ ప్యాటర్న్ కూడా కొంచెం
బెట్ చేయాలి ఇప్పుడు.
యా
Always you should bet on certain things, and then that strongly you need to read.
యా
Battery. Okay, from the thing.
Hmm?
Yes, sir. Malaga, even your laptop looks active.
అయిపోతుందా ఇది? అయ్యో,
Charging.
అక్కడ ఇది
అది కాదు. పెద్దది ఉంది.
ఇది.
So I'll just ring my mom and come. She
Hmm.
when it rings to call.
Right. So let's continue the journey, doctor. Sorry for an interruption. Yes. So what is the best way you can know neovascularization? The fundus fluorescein angiography. You will basically inject a dye into the cubital vein. And then that fluorescein fluorescein will go and fundus will be found. There you can identify, right? Then what is the advantage of OCT? OCT can make you to know how much macular edema is there. And what laser is used to treat diabetic proliferative retinopathy? Pan-retinal photocoagulation. So the funda is, whenever there is ischemic areas of the retina, that stimulates vascular endothelial growth factor, which is leading to neovascularization. So you basically apply burns and kill all those ischemic areas. So pan-retinal photocoagulation. And also we use the anti-vascular endothelial growth factor get administered. What is that anti-VEG of drug oxygen? So always for diabetic retinopathy, treatment is anti-VEG of drug. उनका drug का नाम क्या है? Can the online students can punch the voice loud and clear, doctor? In the SEPA. What is that drug called? Bevacizumab.
Bevacizumab.
Bevacizumab. Ranibizumab. Or Beva.
Sir, Beva and Rani.
Bevers.
Bevers and Rani. Yes.
Bevers and Rani.
Intravitreal injections.
So గుర్తుపెట్టుకోండి, one monoclonal antibody will come. Then comes retinoblastoma. The most common intraocular tumor in a child is retinoblastoma. What is that gene? 13q14.
Retinoblastoma. Short arm of.
So how will you remember 13q14 at 13 ani? Retinoblastoma. Once we enter our puberty at 13,
Yeah.
तब लड़के लड़कियों के ऊपर, लड़कियां लड़कियों के ऊपर आंख लगाना शुरू करते हैं. So 13 is retinoblastoma. Then it is autosomal dominant with incomplete penetrance. There is a white reflex called leukocoria. And second most common is strabismus. The histopathology of study. Flexner, Wintersteiner, rosettes are typically found in retinoblastoma.
Morning, sir.
Yeah.
What do you remember? Trilateral retinoblastoma, bilateral retinoblastoma plus pinealoblastoma. Most common way is directly it will spread outside the eye. Direct extraocular occlusion. Later it can go to the bone marrow. And what do you find? Typically when you do CT imaging, you will find calcification of the retinoblastoma is the most common imaging finding. And what is a very close differential diagnosis for a white color inside the eye globe, leukocoria? It is a congenital cataracts can also present with leukocoria, right? Then, yes, whenever sporadic somatic mutation of 13th chromosome is there, you get unilateral. Whenever it is a germline mutation, then it is bilateral. Somatic ante पैदा होने के बाद, पैदा होते वक्त कुछ भी नहीं है, बाद में म्यूटेशन हो गया, that is somatic. While born only you brought germline mutation, that is bilateral. Then the same RB gene will also lead to osteogenic sarcoma, is the second malignancy that happen in case of retinoblastoma. Favorite question. Huh?
Yeah.
What is the second most common malignancy in retinoblastoma? Osteogenic sarcoma. Then how do you treat if the tumor is small? Laser photocoagulation or cryotherapy. Cold use karke. Treatment of large tumor hai to enucleation. There are two things.
Yeah.
Evisceration, enucleation. When do you do differences? Everything we should know. Then whenever it is bilateral, then you look whether macula involved. Macula is spared. Then you can do chemoreduction along with focal therapy. So, therapy choices are important. Small tumor, laser photocoagulation. Large tumor, enucleation. Bilateral tumor, chemoreduction. The most important prognostic factor is that whether it had an extraocular extension, right?
Yes.
And involved the optic nerve or not. That's the reason whenever you remove the retinoblastoma, no?
Yeah.
You will also take a small piece of the optic nerve also dissected, and then you will check for any mets on it.
Yeah.
What is the age for it?
Less.
Less than 3 years. 13th chromosome. 3 is the lucky number for retinoblastoma. So what is the best test? It's called Bruckner's test, where the red reflex is absent
Yes.
and you get a white reflex.
Good.
Finish. Happy? Opkunda?
Saturated.
Anything up to you.
At least my job is to add a little petrol.
Yes, sir. We
मैं
are
पापा
liking.
పొద్దున చదువుతున్నారు కదా, సో కాబట్టి మధ్యలో నేను వచ్చి కాస్త చీర్ గర్ల్స్ ఉంటారు కదా. My job is to be a cheer girl. Hey, you're playing well. That's what in the last moment. Anatomy ఒకటి చదివేసిపోదాం.
हाँ, sir. Please.
Thickest layer in the cornea is stroma. ముందు ఎన్ని లేయర్లు ఉంటాయి?
5.
5 లేయర్లు ఉంటాయి. Thinnest is endothelium.
Innermost.
And which layer comes from neural crest? Decimates membrane. And what is the cause for the transparency of the cornea? Typically, there you have collagen, right? That orderly fibers of the collagen are responsible for the transparency.
Sir, also it is like blood vessels the conjunctival
Cornea is avascular.
That's the reason also for transparency.
So who provide oxygen to cornea? The overlying atmospheric oxygen.
Aqueous. Oh.
Then lens capsule comes from the epithelium. Lens nutrition comes from aqueous humor. Then what is vitreous? 99% water only. And what type of collagen? Type 2 is vitreous. You can say 2 vitreous. 2 vitreous. Bone 1.
Floor is
Cartilage is 2. Basal membrane is 4.
4. Floor is 4.
Oh.
Floor is 4. So
3
what?
is reticular.
What is angle of anterior chamber? Cornea, iris, trabecular meshwork. These 3 are the components of the anterior chamber. Tarvata, okay. Shortest extraocular muscle, inferior oblique. Longest is superior oblique. Largest is medial rectus. Strongest is medial rectus. Thinnest is superior oblique. Pulley will be there. And optic nerve sheath में क्या क्या रहता? The dura arachnoid paya will be there around the optic nerve chuttu in the sheath lo. Most common ocular muscle palsy is
6.
abducens. Ocular motor abducens, మధ్యలో abducens.
Raised acidity లో దెబ్బతింటది.
Raised intraocular tension. Very good.
Raised intracranial tension లో
అదే ఎందుకంటే abducens will have typically the longest course.
intracranial course.
Intracranial.
It's inside the cavernous sinus.
Third nerve palsy.
Down and out.
No, ptosis down and out.
The 6 low will be in and out.
Which one?
In,
No, they're only specifically down and out is mentioned for oculomotor.
yeah.
So when
First
oculomotor
six, I'm
is
wondering
gone,
what it will
4
be.
and 6 are working.
Yeah, that's
SO
why it will be down and out.
Yeah, that's
But for
4th
6
supplies superior
palsy,
oblique that will push it down.
Yeah.
for 6
Because
palsy,
inferior oblique, which is supposed to push it up, is not
Convergent.
working.
convergent.
Okay.
Then pupil etlunటది? Typically pupil, sphincter pupilla is by third cranial nerve. If the sphincter pupilla is involved
Fixed.
in third palsy, that lead to pupillary dilatation.
Midline.
But in diabetes, hypertension like conditions,
Spared.
pupil sparing will be there only in posterior communicating artery aneurysm.
Yes.
You get pupil involvement. Then sixth nerve palsy ka hallmark kya hai? Eye is moved out.
Yeah. Are they
No,
So esotropia.
Eye is moved inside. sir.
inside?
Inside. Yeah, esotropia. Inability to abduct.
Convergence.
Then most common cause of sixth nerve palsy is raised intracranial pressure. Fourth nerve palsy lo emaitadi? Trochlear lo
Superior oblique depressor కాబట్టి పోతే elevate అయ్యి.
hypertropia. And very important question. Head ఎటువైపు టిల్ట్ చేస్తాడు? ఇటు సైడ్ ఫోర్త్ నర్వ్ పాలసీ ఉంటే ఇటు సైడ్ టిల్ట్ చేస్తాడు టు కాంపెన్సేట్ ఇట్. ఎందుకంటే దానికి కొంచెం లాజిక్ ఉంది లేదు. ఇట్లా తిప్పితే ఆ డిప్రెస్డ్ ఐ కాస్త కొంచెము అలైన్మెంట్ లకు వస్తుంది. దెన్
సార్ ఫోర్త్ నర్వ్ SO4 కదా సార్. సుపీరియర్ ఆబ్లిక్ ఆర్ ఇంటార్టర్స్.
Yeah.
సో ఇంటార్షన్ దెబ్బతిన్నప్పుడు మనం ఈ హెడ్ టిల్ట్ ఇంటార్షన్ ఇస్ ఇన్సైడ్ కదా సార్.
Yeah.
కానీ లీజన్ ఇస్ ఆన్ ద రైట్ సైడ్. ఐఎమ్ సపోజ్ టు టిల్ట్ లైక్ సో దట్ ఐ కెన్ ఇంటార్ట్ ఇట్ ఇన్సైడ్ లైక్ దట్. సో అందుకే ఆపోజిట్ సైడ్ హెడ్.
వాట్ ఎవర్ అట్లీస్ట్ ఇది గుర్తుపెట్టుకునే చాలు. ఫోర్త్ అంటే ఆపోజిట్ హెడ్ టిల్ట్
Yeah.
అండ్ ఐ ఏమో ऊपर जाता hypertropia. And bichapodi head tilt test, Bichowski's is positive in trochlear palsy. అంటే మీరు కనుక ఫోర్సబుల్ గా తిప్పారు అనుకోండి అప్పుడు మనకి డిప్లోపియా వస్తుంది. దాని బిచోస్కి. దెన్ బ్రౌన్ సిండ్రోమ్ అంటే ఏంటి? కొంతమంది సుపీరియర్ ఆబ్లిక్ టెండాన్ మెకానికల్ గా ఆ పుల్లి రెస్ట్రిక్ట్ అవుతుంది. దట్స్ కాల్డ్ బ్రౌన్ సిండ్రోమ్. Then what is internuclear ophthalmoplegia? Whenever the medial longitudinal fasciculus which connects one side abducens with the other side oculomotor is affected. Then what will happen when the eye on this side is abducting? The other side has no information because it should adduct, no?
Yeah.
That's the reason it remains
Central
adductor lag will be there.
Yeah.
Because of that, there is a diplopia. To overcome that, this abducting eye will go into nystagmus.
So yoke muscles are getting this. Yoke muscles are not working.
Yoke ante ide.
Adi sir, మీరు చెప్పింది.
And which side is medial longitudinal fasciculus? It is the side where adductor lag is there. That side, MLF lesion we call it as medial longitudinal fasciculus. Mari oculomotor nerve may not be adducting. I mean, the other eye may not be adducting. Even in case of oculomotor palsy also, no. Not only MLF lesion.
Yeah.
Suppose this eye la oculomotor palsy unte kuda I cannot adduct, no, when this eye is abducting.
Ptosis ఉంటుంది.
No. Most important is look at the object closer. Then both eyes will converge.
Okay.
This eye, suppose if it is internuclear ophthalmoplegia,
Yeah.
the adductor lag is the problem only when the other eye is abducting,
Okay. Sir.
not when you are looking at an object close by. That time it will adduct because it has no need of coordination with the
Opposite.
opposite side. Right? So what is 1.5 syndrome? Suppose if there is an internuclear ophthalmoplegia, at the same time, if there is a ipsilateral horizontal gaze palsy, right? The side where internuclear ophthalmoplegia is there, akkane oculomotor palsy kuda undanukondi. Then that is called 1.5. Then what is Mobius syndrome?
There is also.
It is 6th and 7th palsy bilaterally is called Mobius syndrome. Where is the third nerve? Nucleus, midbrain. Third, fourth, midbrain. 5, 6, 7 in pons. Then that's a point.
So that
Okay,
Mobius is nothing but 8.5 syndrome.
Mobius ante congenitally. They have a palsy. Bilateral ga 6th, 7th. Rendu egiripotayi.
So 8.5 is 7th facial nerve along with 1.5.
8.5, I don't know.
Undi sir.
Unda? Okay, maybe. Out of syllabus. Duane syndrome type 1, type 2. Anyway, Duane syndrome ante entandi? Abduction. Limitation of the abduction of the eye and retraction of the globe. Both abduction, adduction of the globe is affected and type 2. Type 3. అది అవసరం లేదంతా. ఇది ఇంపార్టెంట్. పరినాడ్ క్లినికల్ గా చాలా సార్లు చూస్తారు. మిడ్ బ్రెయిన్ లిషన్ ఉంటాయి.
Yes.
Pineal gland tumor, pinealoma. If it is causing the compression of the tectum of the midbrain, then they will get a upgaze palsy. They can't look up. Then there is a light near dissociation. This combination is called Parinod syndrome.
So
Shanti, Shanti, Shanti.
What is logged in, sir?
Logged in means whenever there is
Yeah, they come.
logged in ante whenever pontine, in case of central pontine myelinolysis, pons is the center of differentiation. All your motor path going to the upper limb, lower limb, everything passes through the pons. Just like thalamus is center of afferentiation. So the moment there is a overzealous correction of the hyponatremia, more than 10 milliequivalents, then the pons will suffer demyelination. The moment there is a demyelinated pons, central pons, then what will happen?
All the efferent is affected.
All the efferent is affected. He can't hata pama utna band ho jata. Or aank bhi horizontal gaze gone.
So only
But vertical gaze is controlled
midbrain.
by midbrain. So that is intact. So like a frog, he will be moving up and down. His consciousness is intact. But his legs, everything are not working. That's called central pontine myelinolysis is what we need to remember. Thank you, doctor. And we will all see you tomorrow. Read.